I'm going to pass straight across to Derval to introduce now our next panel discussion, which is with some frontline workers involved in delivery of care services in this area. Thank you, Derval.
Thanks a million, Paul. So we are now going to look in this session at the impact of harmful drug use through a very, very different lens, and it's that of our frontline workers. And what we have on stage are four very, very different but related disciplines, but what they all share is this sort of a unique bird's eye view on the issues that we're discussing and the harmful impacts on individuals, on families and communities. Just to introduce them all to you, Tom McLaughlin to my far right is an advanced paramedic based in Swords Fire Station. Beside him, Elaine Keogh. Elaine works with Merchants Key Ireland and is the clinical nurse manager at the St Francis Farm Detox Unit in Tullow in Carlow. Maria O'Hara is a detective in the National Drugs and Organised Crime Bureau, and Dr Chris Luke has a 40-year career working as an ER doctor in Dublin, Cork, Liverpool, Edinburgh, the whole works. And so first of all, welcome to you all. And Chris, I'm going to start with you. First of all, maybe just paint a picture for us when we get into the ER room, into A&E. What type of people are you seeing, and what type of drug use are you seeing, and what are the impacts, I suppose, maybe just at a physiological, psychological level when they hit the ER suite?
Yeah, thanks, Derval. I suppose everybody at this stage realises that our emergency departments are completely overwhelmed, you know, in every town and city in the state. I mean, there's about 30 of them, and they're all basically overloaded 24/7. And I often talk about drink and drugs to parents, and I try to explain to them that very many of the patients within the emergency department, and I include the elderly on trolleys, you know, because as far as the eye can see, you're going to see trolleys and people with the people on the trolleys. You'll see full waiting rooms and so on, and you'll have ambulances queuing up. And a great number of the people there are actually there by choice, but it's not that they've chosen that day to arrive in an emergency department recreationally, but it's just that the choice they've made over a lifetime, for example, tobacco consumption, alcohol consumption, or mistaken consumption of prescribed meds, or inappropriate consumption, as well as all the illicit drugs we've sort of talked about so far. So I mean, for example, tobacco kills 50% of its users, and a huge number of the people in the back areas of emergency departments are there with tobacco-induced lung disease, leg disease, heart disease, strokes, and so on. And the same, obviously, with alcohol. Alcohol fills our emergency departments, particularly in the evening. And particularly, following, road traffic accidents or violence on the streets and so forth. In terms of illegal drugs, they tend to come into us in the afternoons and the evenings. And as I explained, they're coming in. These people are coming into already bursting emergency departments, and that immediately makes it difficult because, as Tom will attest, the ambulances are trying to actually decant patients who sometimes have to wait in the ambulances for 4, 6, 8 hours or longer because there's no space for them in the emergency department. So that's the context into which, for example, a 17 or 18-year-old boy who's having an acute cannabis-induced psychosis arrives. And he can be extremely agitated, sometimes violent, but very difficult to restrain and very, very noisy. He is frightening to those around him, particularly the elderly people and the family members and the companions. So anybody with an acute psychosis, drug-induced, whether it's cannabis, common cause, cocaine, very common cause, and so on, will be very frightening. And one of the things we haven't heard yet in terms of our discussion is that, drug taking can make people very difficult to deal with, because they can be very addled, very muddled, they can be hallucinating, they can be deluded, they can be having all sorts of physical conditions. And again, Tom will be very well aware of that. Almost every day you'll have an opioid overdose of some sort where the patient becomes blue, they stop breathing, they have pinpoint pupils, and they may be grey by the time they get hopefully the famous Narcan or naloxone, which is the antidote. Or they can be a cocaine agitation delirium, which is typical, for example, on the streets in or outside clubs. You'll often get violence with the doormen at clubs, propelled by the cocaine we've heard about so eloquently from Fionn. But for every 10 guys kicking off at the door of a club, one or so will proceed into severe cocaine-related delirium, agitation, violence, or sometimes an acute stroke or heart attack or seizure. So there's an enormous range of drug-related presentations to the emergency departments. The number one problem is we're already packed out with lifestyle issues, and drug issues can be very, very difficult to deal with as a result.
So I might just pick up on that, Tom, because you're an advanced paramedic, so you can go in. I know the name of the medication that literally can sort of try and revive people back to life, but you can dispense those as an advanced paramedic. But when you get the call out and it's a drug-related incident, what types of scenarios are you facing? Where are you and your colleagues being brought to?
So what generally happens when someone rings 999 or 112, no one usually ever says it's a drug-related incident or never says it's a drug overdose. They would normally tell you on the phone that it's a collapse or this person's unresponsive or unconscious or is not breathing. So that goes in as a Category 1 call. So it's what we term as an echo or delta call. And usually that gets a fire EMS-based response from Dublin. So you may have a fire engine and an ambulance attending that scene. And usually if it's an overdose type scenario, you're met with really kind of 4 typical scenarios. And the first scenario would be that someone has overdosed, is unresponsive, and you do assess and treat them, and you do give them the naloxone drug to try and reverse that cause. And usually what happens with that type of individual is that they get the treatment, they now become conscious, and then they refuse any further treatment or transport. And that's a big concern for us because we want them to go to hospital to get definitive care. The second type then would be where...
can they be, just as Chris was outlining, can they be aggressive about that? Or?
So that's another type of individual. So that type of individual, if if they're unresponsive or unconscious, and we reverse the cause of the drug overdose by giving naloxone, that person may get aggressive and violent and may not want, obviously, to go to hospital either. And then, obviously, we may have to get the guards involved in that type of scenario. And then there's violence and aggression towards the crew, and then you have to think about the safety of the crew. And that can be quite a difficult situation to manage. Of course, then there's the other type of scenario where you may give the person the naloxone and they're quite happy to go to hospital. They may decide, yeah, this is what I need to do. Didn't realise I was in this situation, and are very grateful to you that you're going to bring them to definitive care. And of course, the last one, is the one we don't want, is that when you arrive at the scene and this person is dead, and you're trying to revive the person, and that may work or may not work. So they may be verified as dead at the scene, or they may travel to the hospital and die at the hospital. So that's quite common as well. And of course, we have to consider the environment we're in a lot of the time. So those environments could be someone's home, it could be a hostel, or it could be down some dark, wet alleyway in the city centre. So the environment plays a part in the response and how we manage that case.
And when you say even just in someone's home, I think there's a tendency, perhaps our deep ingrained biases, we might think, well, it'll be the hostel, it'll be an alleyway, or it'll be a certain community, but does it bring you to, does your work, particularly when you're looking at drug-related harm, bring you through all strata of society?
Absolutely does. Nowadays it does. It probably didn't many years ago, but certainly it does now. So, I would have worked across the city and would have experienced and attended cases of drug misuse or drug abuse or overdoses in various different areas. Now, it probably wouldn't be as prevalent in the likes of sort of Donnybrook and Rathfarnham, but certainly in sort of Tallaght, Dolphins Barn, Finglas, and Fisborough, those sort of areas is probably more prevalent there, and the crews would see them more frequently there. So yeah, but again, it's like that last week, for example, or in the last 2 shifts I worked, I attended 2 overdose cases. One was in Swords, and unfortunately that person died, and the other one was in Donabate. And they're not places you would normally associate with drug overdose or heroin overdoses in particular, So it's right across the board.
Maria, before you joined the National Drugs and Organised Crime Bureau, you were in uniform, you were on the beat, you were based in the city centre in Pierce Street, so not far from Temple Bar, which we've just been reading about in the last 24, 48 hours about renewed concerns about drug use in that area. With that being on the beat in the heart of the city, what kind of incidents were you coming across? You know, what scenarios or what kind of range of offences were you dealing with?
So just to keep on the topic in relation to talking about overdoses, I think my first week as a uniformed guard in Pierce Street, Temple Bar obviously is a very busy area, and any call could come in at any time, but as Tom had said, a call had come in, just a male collapsed on the street at Fleet Street Car Park. So just speaking on arrival, going to the scene, I was along with my colleague, and my colleague at the time knew this man that was collapsed, and he was speaking to him by name. And he was semi-conscious until the point that he had obviously lost consciousness then. The ambulance services were called, and then they had arrived, and obviously I had observed the administration of the Narcan or the naloxone, whichever one was used. So just in them instances to see, like, you know, the preservation of life was key in this instance, and making sure that, you know, he was okay and that he actually went off to hospital, and he wasn't violent or anything like that. But in all instances, as we see, you know, drug use and all, we also have to have a duty of care to look after and very much make sure that they're okay as well. Because
there is, Maria, a dual aspect to what the Gardaí are doing. There's obviously the public safety aspect, that sort of criminal justice public safety aspect, but there's also the personal safety. There's a welfare role, isn't it, often for the Gardaí when they're coming into scenarios like that?
Well, absolutely. Public safety is paramount, and, you know, drugs don't discriminate. You know, they affect everybody in their lives, and, you know, duties would have also included the likes of being station gaoler at Pierce Street Guard Station, where you would have had numerous amounts of people that have been arrested coming in and out of the station. And in one instance, I remember a very violent male one night come in, and he had to be taken in by 4 or 5 strong men, and he actually was a veterinary student, believe it or not, and he was after taking ketamine, and he was, I'd say his body strength was 20 times what it usually would be like, and it was such a difficult night to try and look after him, and, you know, instead of looking every 15 minutes to see was he okay, it was every minute to check that he was not doing any damage to himself, and the duty of care and the safety of looking after him as well, obviously.
What are the range of offences, Maria, that you encounter when you're on the beat? Like, I mean, obviously, the worst is when there's been an unlawful killing or extreme violence. But what are kind of the impacts of it? Seen, particularly around a place like Temple Bar, where you might say, well, there's a lot of petty theft or things like that.
In my personal experience, while I was a beat member in Temple Bar, I've seen a myriad of offences, ranging from assaults, violent disorders, public order, every offence under the Public Order Act, thefts, burglaries, obviously drug taking. You know, it's like, obviously there's been suicides, people attempting to jump into the Liffey, pulling them off bridges. It ranges. Every day is just so different, and you could just come across really anything. You just have to be prepared to be able to, you know, deal with it.
Elaine, we heard earlier in that very first powerful session about how nobody sets out to be an addiction. Nobody plans it, and often those who have problematic or dependent drug use have really, really complex needs, and that's where your frontline, I suppose, interacts with these people. What are you seeing at Merchants Quay and at the farm when people are coming in looking for your help?
Yeah, so I suppose our residential service in St Francis Farm is for people who are on methadone and who are on benzodiazepines, and we do a medically supervised detox. So that's a nurse-led service, and GPs come in and reduce people off of that. So I suppose we've heard a lot of this very acute and frontline stuff that's happening. I suppose this is the service in Tullow is much further down the road, where people are looking to come into a residential service to come off of these drugs that are prescribed by the GPs. I suppose the background is that people have very complex needs, as you mentioned, and we heard some of the stories in the last session, where the addiction is one piece, but there are many other pieces. And I suppose from my experience working in St Francis Farm, a lot of it is around mental health. there's mental health issues there, whether they're diagnosed or not, and there's a lot of self-medication and around drug use, and that tends to be where a lot of that the addiction comes in.
And like, I mean, it can be, just even hearing Chris talking about, the A&E, but even for a person who's got capacity and who's got resources, navigating our services can be really, really challenging, whether it's mental health or other services. The people who are coming seeking your help must have extraordinary difficulty in having their needs met, especially if it is a dual diagnosis or they're eligible for that service but they're not eligible for that. Their capacity.
Sure, it's very complex, and I suppose even for me as a nurse and someone who works in the services, it can be very hard to navigate around the services. So I've had experience with people saying that they just don't know where to go. We get a lot of phone calls into our service in Tullow with people asking how, from families and from people in addiction, where do I go? Where do I start? How do I start this process for myself to get some help? So I suppose that's the first piece. And then the next piece is around that there are so few services available that it takes a long time for a person to access those. And I suppose the waiting lists that we would see, and then people unfortunately are not able to maintain the level of just staying on their medication and not taking anything else, and then are not able to access the service when their time comes to come into it.
And then it's so easy then to slip back and to relapse. Tom, I was interested, we were just chatting earlier to Gillian about her late father was one of the first casualties of the heroin epidemic in the 80s. What is the biggest change that you have seen in terms of drug prevalence, drug use, but also maybe the type of drugs that are being used in your work as an advanced paramedic?
Yeah, so the term polydrug use is more common now, where there's like back in the 80s there was probably a drug of choice. Heroin was big in the 80s. It seemed to have died off when the kind of AIDS, HIV pandemic kind of kicked off, and then other drugs took hold. It became the drug of choice then. But in modern days and today, cocaine is huge around. We see cocaine a lot around the city. But people are using more and more drugs and different types of drugs together. And that poses a big problem.
Is this the synthetic, the kind of the...
Yeah, so you have obviously the ketamine that was mentioned there.
Fentanyl?
Fentanyl is not as popular, but it's there and it's very hard to detect. Unless someone's telling you they're taking fentanyl, you won't see it that often. But you certainly see the paraphernalia for heroin use. You'd certainly see the paraphernalia for
Is heroin
cocaine.
back?
Heroin is definitely back, yeah. Heroin. I've been to a good few heroin overdoses over the last while, yeah. Heroin's still there, and it's definitely back if you want to use that term. Pills, of course, pills are being used quite frequently as well. So the ecstasies and the LSDs and the benzodiazepines, they're all still being used, So it seems to be widespread, to be honest, and polydrug use seems to be the case. And what happens when we arrive at the scene is that a lot of the time we actually won't know what you're
dealing with.
And you have to play a bit of a detective in trying to find out what drug was taken, unless someone's there to tell you. If it's a family member, they may tell you, or if there's a key worker there, they may know more information. Sometimes if it's, as I mentioned earlier on, down an alleyway, the person that they may have been using a drug with has probably
absconded because they're afraid of the criminal impact. Chris, I want to ask you about this because there is a lot of discussion and debate outside of this room, outside of this assembly, about the need to not only decriminalise cannabis, but also to possibly to legalise it. There's a strong lobby, but can you tell us something about the extent of drugs like cannabis, their use, and your own thoughts maybe on that?
Yeah, it's a very vexed issue, Derval, to put it mildly. I mean, it's as polarised as American politics, I would say, the cannabis debate, for example. There are some broad themes. We know, for example, that since the legalisation of cannabis in Canada and North America, the States, that the use of cannabis by young people and adults in general has gone up by about 6-fold. and that it stays up. So you can start with medical or medicinal cannabis legalization, but once the usage goes up within a population, it seems to stay up. That's what the first 5 to 10 years have shown us in the States. Similarly, if you legalize cannabis use, as they have done in North America, you'll see the numbers of people attending the emergency departments surge. You'll see what we've seen recently in Temple Street. You'll see a surge in the accidental poisoning of youngsters
Which is
with
Children's Hospital?
gummies and edible cannabis. That's very popular. You'll see that happen particularly when the parents are smoking, weed, or parents are drinking, or whatever they're doing. If parents are not with it, if their consciousness and vigilance levels are impaired, their children will come to harm. As we've sort of indirectly heard already today.
I recently read a piece in the Irish Medical Times that you wrote, some of it tongue-in-cheek, but actually your main gripe, as I understood it, with cannabis use is its connection to violence and to what you describe as third-party victims. Can you tell us about that?
Well, there are 4 groups of presentations with every drug, and Tom will realise this. There's the acute use. You smoke a few spliffs and you become euphoric or sick. Or you may have an abreaction. You may be suddenly very, very sick. You may vomit. You may become nauseated. You may hallucinate. Then there's and that's the same with alcohol or ketamine or whatever, like the ketamine reaction with the veterinary student. That's very typical. People who become intoxicated with certain drugs and who become psychotic. They have, I've heard it said that the Incredible Hulk comic is based on cocaine and the effect of cocaine psychosis on people, and how little weedy people can become extraordinarily powerful. And Maria described something which we see every week in an emergency department in this country, where you have 6, 7, 8 guards, security people or whatever, sweating, trying to restrain some apparently slim, built individual who's in a psychosis for whatever reason. And as Tom has implied, it may be 6 weeks, 6 months, or never before we discover what they've actually taken. So it's sort of it's guesswork according to the features of the dilated pupils or the pinpoint pupils and all that. But the chronic consumption of any drug will lead to the well-known effects. So cannabis, we know about psychiatric issues. We know that if you have one episode of cannabis-induced psychosis, that 50% you'll have a 50% chance of developing schizophrenia or bipolar or other psychosis. So cannabis. Heavy, not the odd spliff. We're not talking here about the odd anything. We're talking about people who are smoking several spliffs a day or bongs or whatever, and who have a vulnerability. This is the issue.
Which is an issue which came up from.
So basically, so far medically it's accepted in terms of epidemiology that between 10 and 20% of heavy users will go on to develop what's called a cannabis use disorder, which is where they get the cravings. They might be very irritable. We've heard about, and they develop. They withdraw from society, including their own family. They'll withdraw to their room and only emerge periodically to get their supply. There's other things that are emerging. For example, cannabis hyperemesis syndrome, which is something they're beginning to see in the emergency rooms all around the States, where you get young adults, males typically, who find that they have terrible vomiting and abdominal pain. And they've discovered that the only thing that relieves that is a hot shower. So that's a classic giveaway. Someone who has sometimes an undisclosed history of heavy cannabis consumption, but presents to the emergency department because they've been vomiting for days. And they're sweaty and exhausted and can't sleep, and they're brought in and they admit that the only thing that works is this hot shower. That's a classic thing of heavy cannabis consumption. The third group is the third party, people who are victims of violence, random violence on the streets that Maria deals with, and that's what I worry most about. That's actually what I worry most about. It's the violence I worry most about. Like people who are withdrawing from cannabis. Classically, the parents will report that their young son, who was a lovely, sporting, scholastically successful boy, is withdrawn into himself, and he gets incredibly angry if you try and discuss his habit with him, or if he doesn't have enough cannabis to go. So withdrawal like that, often associated with anger and irritability, sometimes violence. And the fourth is withdrawal. Yeah.
It's interesting. I was listening to a podcast in which a lady was musing. She was saying it's interesting in terms of addiction that one of the two areas where people are described as users is drugs and digital screens, the screens that we use, but
yes.
it's like that taking away from people. Maria, I want to talk to you because obviously you've given us this perspective of what it's like on the beat, but now obviously you're a senior detective at the National Drugs and Organised Crime Bureau. So you have a different perspective and lens on some of the issues that Chris and others have raised in respect of the link between what happens at an individual or family level versus what is happening at a society level, and that is the organised crime networks. And I think you said something else earlier about how, drugs don't discriminate. And it's that link, I think, when we talk about sanctions or anything like that, we're like, well, what about the individuals? But people seem to want something for, well, what are we going to do? Fionn talked about it earlier as well, about you see it at the organised crime level.
Yeah, so in dealing with organised criminal gangs, I suppose there's a direct link, is what we can see, going back to the people that use drugs on the street. And, you may go into a search of a house and there might be designer handbags and very high signs of wealth. And, I suppose it all goes back to the poor drug addict on the street who's actually paying for these elaborate signs of wealth, So that's a direct link that we would see,
Yeah. And then obviously just with at both ends of the spectrums of your work within Garda Síochána, you're seeing it at those both levels, the family level and as well as at that bigger level.
Yeah, like the destruction the families are going through, just some people end up in these situations, they don't want to be in them, but they have to do them, and it's just very common that it happens.
Elaine, just before we hand back to Paul, to go to the roundtables, I had a question that I wanted to ask yourself and Tom, and that is the impact of dealing with addiction in individuals in the communities on those who are providing the frontline services. Do you and your colleagues experience high levels of burnout? Did you hear, is it vicarious trauma that I know you're obviously very skilled and very trained, but what is it like being on the front line of some of people's most challenging life experiences?
Yeah, it is. It's challenging. It can be frustrating at times, and I suppose there is that vicarious trauma that you're experiencing because you are hearing a lot of stories. Everybody has a backstory. I think you mentioned that earlier. A lot of them are very traumatizing and difficult to hear. So I suppose there's burnout within the sector, definitely. It is something that you really have to mind yourself in this area, and I suppose the support of your colleagues in this as well is really important to be able to keep working and supporting these people through this process, because it is very difficult for them, but you have to take on that with them to
you're equally frustrated trying to get it,
to navigate them and
yeah.
to advocate for them, and I suppose you have to put on the professional front and keep that, so it is challenging, yeah.
And Tom, equally, would you and your colleagues have to debrief, particularly after maybe having to get help to get out of a very, very difficult, perhaps a violent situation?
Yeah, absolutely. It can cause a certain amount of stress for crews, for practitioners dealing with these situations. But on top of that, we had the practitioners, the paramedics, the advanced paramedics. We all have a duty of care, so we all want to do the best for the individual. And it'd be quite frustrating at times when, I gave an example earlier on where someone might be unconscious and they now become conscious and then refuse any further treatment or care. And we try to explain to them, look, that you're doing yourself more harm. But once they have capacity and they refuse consent for further treatment, then they have the right to do that. And that can be, for us, it can be quite worrying, because we know, for example, using a naloxone, the half-life of that is between 30 and 90 minutes. And when that wears off, they may revert back to the way they were before we arrived. So there is concern for that. And our lads, our guys and girls, will try to do the best we can for everybody. So that's why we get,
Chris, fine.
I should add, I started working in A&E in St. James's in Rialto in 1983. That's 40 years ago. And we were experiencing that because naloxone had just arrived, basically, and we'd have addicts coming in blue and not breathing. We'd give them an injection, an intravenous injection of the naloxone. They'd wake up, they'd pull out, they'd you reckon me buzz, they'd be very aggressive, and then they'd storm off, and they'd be found dead 20 minutes later because the naloxone worked briefly and then wore off, and the large amount of opium or opioid already in the system then stopped them breathing again. So just to tie in with it, it's very exhausting. It's very dispiriting when you have that. I mean, the trick we learned way back then, 40 years ago, was to give them an intramuscular depot injection in both thighs. That seemed to help, but the reaction can be very dispiriting, and then they're back in again a few days later.
Of course, we don't particularly want to get the guards involved.
No.
If someone's not consenting and we're worried about their welfare, we find it difficult to leave the scene, and we may decide to call the guards to see if they can persuade the individual to go to hospital, or certainly if they get aggressive, we may have to call the guards anyway. And that kind of criminalises the whole thing more, and we kind of try to avoid doing that. I mean, we're there to help and care for these people, for these, to try and sort them out and get them definitive care and get them back to where they want to be,
You will again get an opportunity to ask questions of Tom, Elaine, Maria and Chris, but for now, Paul, I'll hand you back for the round table and we'll see you shortly. Thank you.